Usually when we look at a massive systemic global health crisis, there's this expectation of like high visibility.
Right, yeah. You expect obvious warning signs.
Exactly. We look for flashing sirens, front page headlines, and a very clear, unambiguous target to fight.
Because, I mean, we prefer our medical adversaries to be obvious. The human brain really wants to see the threat mapped out with clear boundaries.
But then you look at the actual epidemiological data and you realize one of the most widespread health conditions on the planet is basically just hiding in plain sight.
It really is.
We are doing a deep dive today into a stack of recent clinical trials, medical reviews, and specifically this incredibly comprehensive foundational document. It's simply titled ironoral.pdf. And honestly, the very first statistic in the source stopped me cold.
I know exactly which one you're talking about.
Yeah. Over 1/4 of the entire world's population is anemic, and about half of that staggering burden comes specifically from iron deficiency.
It is a profound global public health issue. Yet, culturally and clinically, it is frequently treated as this minor, almost trivial complaint.
Like it's just a lifestyle thing.
Exactly. People brush it off. They assume they're just working too hard or, they haven't been sleeping well.
They say, oh, I just need another espresso, or I'm just stressed out. But our mission for this deep dive today is to shortcut your path to being totally well-informed on this hidden epidemic.
Which is so needed.
Because we're going to separate some very entrenched, outdated medical myths from the surprisingly counterintuitive modern science of iron replacement.
The science has shifted dramatically.
It really has, because if you or someone you know is constantly exhausted, the solution might be entirely different from what standard advice dictates. Okay, let's unpack this.
Where should we start?
Well, before you can fix a problem, you have to know you actually have it, right? And looking through the source material, the way this deficiency actually manifests in the human body ranges from the predictable to the deeply, deeply bizarre.
Yeah, the standard presentation is what you'd expect. It involves generalized weakness, headaches, decreased exercise tolerance.
Fatigue.
Right, profound fatigue, irritability, and depressive symptoms, too. These are the nonspecific flags that unfortunately often lead to misdiagnosis.
Or they just get dismissed entirely.
Exactly. But the highly specific clinical markers, that's where it gets strange. The literature specifically highlights pica, and more specifically, pagophagia.
Which is the intense, uncontrollable craving to chew and eat ice. I was reading the case studies, and we aren't talking about casually chewing the last ice cube in your drink at a restaurant.
No, not at all.
These are patients going through literal bags of ice a day.
Yeah. The mechanism behind pagophagia isn't entirely understood, but the correlation is incredibly strong. If you observe someone compulsively crunching ice, iron deficiency should be the immediate clinical suspicion.
Wow.
You also see bituria, which is passing reddish urine after eating beets, and a really profound link to restless leg syndrome. Right. That uncontrollable neurological urge to move your legs at night is heavily associated with diminished iron stores in the brain, particularly involving dopamine regulation.
The neurological impact is just wild to me. But the source makes a crucial medical distinction here. And it's a point I think a lot of people, and even like some practitioners, gloss over entirely.
The anemia threshold.
Yes. You do not have to meet the clinical criteria for anemia to feel terrible.
That's such an important point. Anemia is a late-stage lagging indicator. It tells us your hemoglobin has already dropped below physiological norms.
Which is bad.
It is. But your body prioritizes maintaining hemoglobin at the expense of everything else. Long before the anemia threshold is ever crossed, your peripheral iron stores, which we measure by the protein ferritin, they can be virtually non-existent.
The analogy that came to mind while I was reading this is, well, it's like a car engine running on fumes.
Okay, I like that.
The red warning light on the dashboard, which represents the clinical diagnosis of anemia, hasn't flashed yet. The car is technically still rolling down the highway.
But barely.
Exactly. The engine is sputtering, the AC is off, you have zero acceleration, and the entire system is struggling just to maintain baseline function. I mean, mild iron deficiency without anemia still drives severe fatigue and exercise intolerance.
What's fascinating here is how clearly the clinical trials validate that exact physiological state.
Tell me about that.
So the source details a specific trial involving 90 non-anemic premenopausal women who presented with severe fatigue and low ferritin, specifically levels at or below 50 nanograms per milliliter.
Okay.
And researchers didn't just ask them how they felt. They used validated empirical fatigue scales. When these women received intravenous iron to restore those depleted stores, their scores on the fatigue scales improved dramatically within just 6 weeks.
And they weren't even anemic.
Right. Other peer-reviewed trials show that replenishing iron in non-anemic populations optimizes sleep architecture, athletic output, and even resolves structural issues like brittle fingernails.
So the clinical target isn't merely, dodging anemia. The goal is optimal storage. The documentation states the general target ferritin level should be at least 50 nanograms per milliliter. But for specific localized issues, the threshold is much higher. You need a ferritin level greater than 75 to manage restless leg syndrome and greater than 70 to effectively treat iron deficiency-related alopecia or hair loss.
You're aiming to fill the physiological reservoir, not just keep the warning light off.
Right. So if my ferritin comes back at 15, my immediate instinct, and I think the instinct of the broader wellness culture in general, is to head straight to the grocery store.
The dietary fix.
Yeah, I'm going to buy a ribeye steak, some beef liver, and just a mountain of spinach.
Yeah.
Food is medicine, right?
Sure, sounds logical.
But the math in this medical review completely dismantled that strategy for acute treatment.
It really does. Because, look, dietary intervention is an excellent maintenance tool. A healthy, balanced diet absolutely prevents deficiency. But the stoichiometry of dietary iron absorption proves it simply cannot treat a severe clinical deficit.
Let's break down the actual numbers from the text because they are pretty eye-opening. Menstruating females require roughly 18 milligrams of iron daily just to maintain their physiological baseline.
Just to break even.
Right. However, the average daily dietary intake hovers around only 13 to 14 milligrams, so they are already operating at a structural daily deficit.
And when you analyze foods traditionally categorized as iron-rich, like your fortified cereals, organ meats, dark leafy greens, you are only dealing with a few milligrams of elemental iron per serving.
It's tiny.
It is. If a patient's ferritin is in the single digits, attempting to replete their entire bodily iron store through spinach salads is mathematically futile. Full replacement requires the high concentrations found in clinical oral or IV formulations.
I found myself thinking of the body as a bathtub, where the water represents your iron stores. If your tub is completely dry, using dietary iron to refill it is like trying to fill a bathtub with a leaky drain using a teaspoon.
That's a great visual.
It's just not going to work. You need a fire hose, the clinical supplements, to get the water level back up to baseline.
This raises an important question, though, and it touches on the most critical diagnostic rule in hematology. Why is the bathtub empty in the first place?
Ah, right.
You have to identify the leak.
Because simply turning on the fire hose doesn't solve a broken drain.
Supplying exogenous iron without investigating the underlying etiology is essentially medical negligence.
Wow.
For menstruating women, heavy bleeding is a frequent, obvious driver. But for males and non-menstruating females, new onset iron deficiency is a glaring diagnostic red flag.
What are we looking for there?
It is highly suggestive of occult blood loss, often from a gastrointestinal malignancy like colon cancer or another bleeding lesion in the gut.
That's terrifying.
It is. If a practitioner simply prescribes an iron pill without ordering a colonoscopy or thoroughly investigating the GI tract, they risk masking a life-threatening carcinoma until it progresses to an advanced stage.
So, assuming we've checked the drain, we've ruled out the malignancies, and we are ready to turn on the clinical fire hose, we run into a biological wall.
A huge one.
Here's where it gets really interesting, because the foundational medical consensus on how to actually take an oral iron pill has been completely upended.
Totally reversed.
The old school paradigm was intuitive, right? If you are critically low on iron, take aggressive doses. Take a pill in the morning, one at noon, and one at night.
And that aggressive multi-dose approach was the undisputed standard of care for decades.
Everyone was doing it.
But advances in cellular biology revealed a really counterintuitive paradox. The human gut has a strict physiological ceiling. It can only absorb a maximum of about 25 milligrams of elemental iron per day from oral supplements.
25 milligrams, that's it.
That's it.
Yeah.
Because iron is highly reactive, it generates dangerous free radicals if it's left unchecked in the bloodstream. So the body evolved an incredibly strict gatekeeper to prevent iron toxicity.
Okay, the gatekeeper is a hormone called hepcidin, and the literature paints such a vivid picture of how this works. I look at hepcidin as like an aggressive bouncer at the door of a super exclusive nightclub.
I love the bouncer analogy.
The nightclub is your bloodstream, and the gut is the line outside. If you follow the old medical advice and take massive, multiple daily doses of iron, it's the equivalent of a rowdy, overwhelming crowd showing up at the nightclub door all at once.
And the physiological response is immediate defense.
The bouncer, hepcidin, just panics. The liver senses the massive spike in serum iron, floods the system with hepcidin, and the bouncer completely locks the doors.
Yep. Nobody else gets in.
By taking more pills, you actively trigger a spike in hepcidin, which shuts down the transport proteins. You end up absorbing less iron than if you took a single pill.
And what's worse, all that unabsorbed, highly reactive iron just travels down your digestive tract, causing severe gastrointestinal distress.
Severe on pain for no reason.
Precisely. The bouncer metaphor aligns perfectly with the pharmacokinetics here. When hepcidin spikes, it actually degrades the transport proteins on the surface of your intestinal cells.
Oh.
And here's the critical detail. Hepcidin remains elevated for up to 48 hours after a large iron dose.
48 hours?
Right. If you take a pill on Tuesday morning, your hepcidin is still locking the doors on Wednesday. Any iron you take on Wednesday is effectively wasted.
So what's the solution?
Therefore, the paradigm shift, the new gold standard in hematology, is alternate day dosing.
Monday, Wednesday, Friday. You basically drip feed the crowd to the bouncer.
Exactly.
A small group shows up Monday, the bouncer lets them in, you wait 48 hours for the bouncer to calm down and the transport proteins to regenerate, and then you send the next group on Wednesday.
The clinical evidence for this is robust. The source highlights a landmark 2017 trial that tracked iron absorption using stable iron isotopes.
Which means they could track it perfectly.
Right. It allowed researchers to measure exactly how many iron atoms ended up incorporated into red blood cells. They divided iron-deficient women into two groups. The first group received a 60 milligram dose every consecutive day for 14 days.
You'll wait.
Exactly. The second group received the exact same 60 milligram dose, but every other day for 28 days.
So both cohorts consumed 14 total pills. The aggregate dosage was totally identical.
Yes.
But the isotopic tracking showed the alternate day group absorbed significantly greater total iron. I mean, they absorbed 175 milligrams cumulatively compared to just 131 milligrams in the daily group.
Less frequent dosing yielded a 33% increase in fractional absorption.
That is huge.
And furthermore, because less unabsorbed iron was traveling through the gut, the alternate day cohort demonstrated a trend toward far fewer gastrointestinal side effects.
So alternate day dosing fixes the hepcidin problem. But looking deeper into the source, the actual environment in your stomach can still completely neutralize the pill before hepcidin even gets involved.
Oh, absolutely. The chemistry is tricky.
This section on dietary blockers is just brutal, specifically regarding the morning routine.
Iron is a highly reactive transition metal. It readily binds to other compounds in the digestive tract, forming insoluble complexes that are physically just too large to be absorbed by the intestinal wall.
Like what?
The primary culprits are phosphates, phytates, and tannins. These are ubiquitous in dairy, dietary fiber, eggs, and notably tea and coffee.
The coffee data is going to break some hearts.
I know.
The fractional absorption numbers are striking. The clinical review shows that if you take an iron pill on an empty stomach with just water, the baseline fractional absorption is around 21%.
Okay.
If you take that exact same pill alongside a cup of coffee, the tannins bind to the iron and absorption plummets to 10%.
It literally cuts the efficacy in half.
And if you compound the error by taking it with a standard breakfast, say coffee, some yogurt, and a bran muffin, the absorption drops to an abysmal 7%.
You are essentially paying for medication only to flush it away.
So what does work?
The biochemical requirement for optimal iron absorption is a mildly acidic environment. Gastric acid keeps the iron in its ferrous state, which is the specific valence required to cross the intestinal barrier.
Meaning acid is good here.
Right. This means any pharmacological agent that neutralizes or suppresses stomach acid, like your antacids, histamine blockers, or proton pump inhibitors, will actively suppress your iron absorption.
I initially assumed from the reading that we just had to avoid acid reducers, but the data shows we can actually weaponize acidity to improve the uptake, right?
We can. Co-administering the iron pill with ascorbic acid, which is vitamin C, alters the local pH of the stomach favorably. A clinical trial demonstrated that taking iron with just an 80 milligram ascorbic acid supplement boosted that baseline 21% fractional absorption up to 27%.
Mm.
A recent 2024 meta-analysis corroborated those findings, noting statistically significant improvements in both hemoglobin and ferritin trajectories when ascorbic acid was introduced.
So the acid keeps it absorbable.
Exactly. The low pH prevents the iron from oxidizing into the less absorbable ferric state.
Hmm.
Though, from a clinical management perspective, we do have to warn that the increased acidity can exacerbate epigastric distress for some patients.
Which brings us to perhaps the most infuriating discovery in this entire document.
The specialty pills.
Yes. When a patient experiences that stomach upset, they invariably go to the pharmacy and look for a solution. The shelves are lined with these premium, expensive iron formulations marketed as enteric-coated or sustained release or gentle on the stomach.
They sound great in theory.
Right. The consumer logic is totally flawless. The pill hurts my stomach, so I will buy the one designed to bypass the stomach. But I was genuinely shocked reading this. The anatomy of the human gut renders these pills almost completely useless.
It is a classic example of pharmaceutical engineering fundamentally ignoring gastrointestinal geography.
How so?
Iron absorption is not a passive system-wide process. It relies on a very specific transport protein known as divalent metal transporter 1, or DMT1.
And DMT1 doesn't exist everywhere, does it?
Not at all. It is highly localized. The vast majority of DMT1 receptors are concentrated in the duodenum and the upper jejunum,
Which is where?
the very first segments of the small intestine immediately following the stomach. But enteric coatings and sustained release polymers are engineered to withstand gastric acid and dissolve much further down the intestinal tract, where the pH is more basic.
So they're structurally designed to release the elemental iron entirely past the DMT1 receptors.
Exactly. By the time the capsule breaks down in the lower intestine, there are no transport proteins available to pull the iron across the mucosal barrier.
That's crazy.
The document even notes that in clinical practice, these sustained release capsules are frequently radiographically visible, or they are passed entirely intact in the stool.
You're literally pooping them out intact.
They provide a false sense of therapeutic intervention, while the patient's ferritin just continues to crash.
The precise feature the consumer pays a premium for is the exact feature that sabotages the treatment. So the basic, inexpensive, immediate release ferrous salts like ferrous sulfate or ferrous gluconate are the clinical standard for a reason.
They dissolve exactly where they need to. However, we must acknowledge the clinical reality here.
Which is?
Even with perfect execution taking immediate release ferrous sulfate every other day, strictly fasting, avoiding tannates, utilizing ascorbic acid oral iron remains a notoriously poorly tolerated therapy.
Right. The source notes that upwards of 70% of patients prescribed oral ferrous sulfate report significant gastrointestinal adverse events.
70%?
We are talking about severe nausea, debilitating constipation, epigastric pain, metallic taste in the mouth, and dark tarry stools. I mean, it severely impacts their daily life.
The mucosal irritation is profound, and noncompliance is the inevitable result. Patients simply stop taking the medication, their physician assumes the therapy failed, and the deficiency persists.
If I'm reviewing these notes and I fall into that 70% cohort, the takeaway seems pretty clear. I shouldn't resign myself to 6 months of daily nausea. The backup plan intravenous iron seems to have moved from like a last resort option to a highly viable frontline alternative.
Intravenous therapy elegantly circumvents the entire physiological bottleneck. By infusing the iron directly into the vascular system, you bypass the hostile environment of the stomach, you eliminate the mucosal irritation that causes the GI side effects, and, crucially, you completely bypass the DMT1 receptors and the hepcidin blockade.
You aren't arguing with the bouncer at the front door anymore. You are taking a helicopter straight to the VIP section inside the bloodstream.
A very precise helicopter. Bypassing the gut allows clinicians to safely administer near-full replacement doses, sometimes up to 1,000 milligrams, in just a single infusion.
That's incredible.
The literature strongly recommends IV iron for patients intolerant to oral formulations, older adults, and patients with inflammatory bowel disease, where the gut is already compromised.
What about bariatric surgery patients?
Them too. It's essential for bariatric patients because surgery permanently alters the acidic environment of the stomach. It's also standard practice for second and third trimester pregnancies, where the sheer iron demand of fetal development outpaces what the maternal gut can physically absorb.
I noticed the source material spent time addressing the historical stigma associated with IV iron. Older medical textbooks often warned of severe allergic reactions.
That apprehension stems from legacy formulations. Older, High molecular weight iron dextrin products carried a legitimate risk of severe, sometimes fatal, anaphylaxis.
That's terrifying.
The immune system would react aggressively to the dextrin polymer. However, those formulations have largely been retired. Modern 4 therapeutics embed the iron within advanced carbohydrate shells, like ferric carboxymaltose or iron sucrose.
So they hide the iron.
Yes, these shells disguise the iron from the immune system, while slowly releasing it into the blood, vastly improving the safety and toxicity profiles.
The economics of it are fascinating as well. I mean, intravenous iron carries a higher upfront cost than a $10 bottle of pills. But the documentation references modeling studies proving IV iron can actually be more cost-effective longitudinally.
Absolutely.
When a patient with severe deficiency receives an infusion, their hematologic recovery is rapid and guaranteed. They miss fewer days of work, they avoid months of follow-up appointments for failed oral trials, and they don't require secondary medications just to manage the constipation and nausea.
If we connect this to the bigger picture, the increasing utilization of intravenous iron represents a philosophical maturation in modern medicine.
How so?
We are pivoting away from archaic regimens that relied on brute force compliance and patient suffering. We now recognize that therapeutic efficacy is entirely dependent on tolerability. A scientifically perfect protocol is completely useless if the patient physically cannot ingest the medication.
Right. So, what does this all mean for you listening? If you or someone close to you is trapped on the treadmill of unexplained, crushing fatigue, finding the exit requires scientific precision, not just browsing the supplement aisle. First, respect the peripheral symptoms.
Don't ignore them.
If you are craving ice or fighting restless legs, demand a ferritin panel. Do not wait for the anemia warning light to trigger. Second, understand that dietary iron is a maintenance plan. Clinical deficiency requires a clinical intervention, and ensure your physician actually looks for the underlying leak causing the loss.
Finding the leak is non-negotiable.
Third, respect your biology. If you are using oral supplements, optimize your protocol. Take a standard immediate release pill every other day to circumvent the hepcidin response. Add some vitamin C and keep it far, far away from your morning coffee.
Save the coffee for later.
And finally, if your gastrointestinal tract rejects the oral route, advocate for yourself. Intravenous iron is a safe, highly effective modern solution.
It fundamentally reshapes how we approach a pervasive systemic issue. But before we conclude, I want to pivot from clinical application to a concept that borders on evolutionary biology, which the source material briefly touches upon regarding hepcidin.
Oh, this sounds fascinating. Lay it on us.
We spent a lot of time discussing hepcidin as the bouncer that blocks iron absorption when you take too high a dose. But hepcidin expression isn't just triggered by serum iron levels.
What else triggers it?
It is profoundly upregulated by systemic inflammation and cytokines. When you contract a bacterial infection or you suffer from a chronic inflammatory disease, your liver floods your body with hepcidin.
Okay.
It locks the intestinal doors, but it also forces your macrophages, your immune cells, to hoard iron internally, pulling it completely out of the bloodstream.
Which seems counterintuitive. When we are fighting an infection, wouldn't we want maximum cellular energy and oxygen transport?
Well,
Why hide the iron?
from a localized perspective, it seems like a glitch. But evolutionary biologists propose this is an ancient, highly conserved defense mechanism known as nutritional immunity.
Nutritional immunity.
Pathogenic bacteria and foreign invaders require iron to replicate and survive. Iron is the limiting region for their proliferation.
Wait, so the body is cutting off the enemy's supply lines?
Precisely. By drastically spiking hepcidin during an infection, the human body actively induces a temporary functional anemia. We lock the iron inside the cells where the pathogens cannot access it. We are intentionally starving the invaders to halt the infection.
That is incredible. The very mechanism that frustrates us when we try to take an iron pill, the bouncer locking the door, might actually be an evolutionary superpower that kept our ancestors alive during devastating bacterial outbreaks.
It is a striking biological trade-off. The organism calculates that the systemic fatigue and lethargy of acute anemia is a worthwhile price to pay to neutralize a lethal pathogen.
That is going to stay with me. It perfectly circles back to the beginning of our deep dive. We like to think of human biology as a simple mechanical machine we can just pour nutrients into.
But it's not.
No, the reality, our bodies orchestrating a deliberate, microscopic siege to starve an invisible enemy, is vastly more complex and awe-inspiring than a simple blood test suggests.
Well said.
Thank you for joining us on this deep dive. Keep questioning the consensus, keep checking those ferritin levels, and we will catch you next time.